or not, or in many cases even the diet that we're creating for the family is a low sodium diet. Those are all things that there's a lot of things that we can put into place where we train the caregiver and hold the caregiver accountable to make sure that happens. But what was interesting and what caught our attention and why we're on this call is when your email talked about that, it's a big focus for us, and we're trying to figure out how we can do that better. And we'd love to see kind of your software and maybe even some of what your service offerings are, what we could learn from you, or what we could do in partnering with you, or even being I don't know what you're offering, but we're all ears because it's a big part of what we want to do.
The other service we're a little bit different because we also do placements as well. So when we meet with family members and discharge planners, we help them decide whether or not to go home and receive care or to go into a facility. So we help direct them into assisted living facilities, adult family homes, board and care homes, memory care units. We won't provide the care, but we'll help find the ideal spot for them, or we can provide care in the home. So we kind of do two things, two different services there, with both of a goal of providing great care, good outcomes for the client and also for the referral source.
And Rob, where do those? Oh, sorry, I was just going to ask, Rob, where do those referrals come from? How do you get new folks into your network to help make those placements?
A lot of the discharge planners, case managers at the hospitals will call us, and in the skilled nursing facilities. Some are web generated leads off the internet, but most of them are usually from a healthcare professional managing a discharge from either a hospital or a rehab center.
Okay. And at this point, do you have any formal partnerships with any health networks or ACOs or anything like that, or is it more just relationships at the local level?
Most of them are local level, but we are in the process of working with a few, not to be named right now, but yeah, we've got a few hospitals, at least up in the Northwest, that we're looking at.
Okay.
But Chad, did I speak over you?
No, you said what I was going to say.
Okay. So let me just do a quick overview of what the software does, and I'll jump right in and show you from the user standpoint. And so we can do in a couple of different models. I'll kind of start with this block over here. So when a patient is entering into the system, and let me actually make sure I'm using the right term. Do you all use the people you care for? Do you call them customers, patients? What would be the appropriate term to use?
We call them clients.
Okay. Okay, great. So for your clients that you have, each time a client is entered, and it can be entered manually or through a data feed. They can be stratified based on that client's criteria, whether it be age, maybe the diagnoses, chronic conditions, what the hospital they came from, and some other factors that determines the level of follow-up that they need, and basically what's called a communication plan is generated for them automatically. And
who creates that? The case manager?
Say that again?
Who creates that communication plan?
It's automatic, that the software does automatically.
Oh, got you. Who's inputting the information into the software? Like, would it be us, or would it be a case manager, or is it one of your people? Who populates the software with the data it needs to come up with that?
So with the model for your locations, it could be either a member of your team that enters the client information, or if you have a system where that client information is already existing, we can have a data transfer, take the data out of that system and into our software.
Let me ask you this, because we're obviously a non-medical agency, but how much of that information is medical by nature? How much of it is something that it may go above and beyond what we normally ask? And how long does how much information does that need, and how long does it take to populate that? Because I'm trying to think what a difference in our current intake process it would be to implement something like this.
Yeah, let me show you what kind of. We're just going to jump in. But these are some great questions, and so can you all see my screen?
Yes.
Yes.
Okay, so I'm going to kind of jump around. These are some great questions, but I want to make sure I can get to it. So to enter enter a patient, it's about 7 or 8 records. Now, the clinical information isn't mandatory, except for just what the basic condition is. So if I want to go to add a patient, I'm just going to show this to you so you can see an idea what the minimum information is to add a patient. And hopefully you'll see it's pretty much within probably the basic information you have. And so if I click save here, it'll show me what's missing. So basically it's the name, location of the patient, as far as which one of your locations. Admit date would be when they entered your care. We have a date of birth, a gender, and then we have just what's a number for that patient and an episode number. So if that patient comes in and out of your care, we track different episodes. And then it's just, the only thing else is where they're at. Are they at home or in a facility? Living now? And that's it. And that's the minimum information you have to add to create a record. And from that, we can still create automatic plans that show that are specific, for either that patient's age. If you want to add additional information like a diagnosis or a chronic condition, you can, but it's not the minimum required.
And that's about it.
But that's the minimum, right? Now, so let me show you. Let me show you how this works, and you'll see how if you choose to add information, you have more options. So I'm going to go and look at my activities for around now, and pick up. Just go to search. So this is kind of where it gets in. I think to jump to the end here. So what we designed is, if I'm right now, let's say I'm one of your team members, and one of my jobs is to obviously to check in with patients, and these can either be in-person visits or follow-up phone calls. And so what we've designed here is that when a patient is entered, I'm automatically assigned a certain number of activities to follow up for that patient. For that client, depending on the criteria that is matching for that client. In this case, it might just be the client's age and location they're in. And for each follow-up activity, for each activity I have, if I click on it, you'll see that there is an agenda that's set for me that I need to follow in order to complete this activity. And so in this case, let's say that client of yours is just been released from a discharge from a hospital. One of the things so what we do is we automatically assemble an agenda of items that person who might be calling, that your team member who's either calling up on the phone or visiting a person, needs to make sure they complete. And these are just best practices that are done by seasoned care coordinators or sometimes even social workers to make sure that they're doing everything they can to check up on, to ensure that that client is on their way to a healthy recovery. And so for each one of these automatically agenda items, I have a script that's guided based on, we have a library but can be customized to you, and information that we, and an answer to put in based on how that patient's response is. And so what this does is, and this kind of gets to your question, Chad. So you saw that the minimum information to put in. If you add additional information, such as the condition of the patient, such as maybe they have COPD, maybe they're having a hip replacement, this agenda automatically has activities or objectives added to it based on that data that you enter. So, for example, you might have these calls that may have 6 activities when you enter the minimum information, but the more information you add in, depending on how you design the activities, the more of the objectives will appear to make sure that you're covering all the bases specific to that patient.
And so, an example would be if you did end up having a partnership with a hospital system and they said, we want you to have, upon discharge, follow up with this type of patient, and this is the protocol we want you to follow. You can customize and build that in here so your folks are doing exactly what you've contracted with them, and then you can report back to them, the activities were completed and the timeline in which they were done.
That's cool. And everything from a case management perspective, all best practices are already kind of baked into the system, right?
It is. So and what happens is that if I go to look at activities for this patient, like I can see here a schedule of automatic activities. Each one is going to have its own agenda specific to that patient, and the number of activities assigned out depends on the amount of time you're caring for that patient. This is an activity I'd already opened on a previous demo, but you'll see is that, so week 1 follow-up, again, you're asking how the patient's feeling, you're asking a little bit differently. And here's where you can help from that case management standpoint. This is what a lot of sometimes groups do is, while they're checking in and making sure that patient's doing well, confirming everything is, been arrived that they might need. It's also, hey, if you feel bad, do you commit to calling us first so we can get you in touch with your doctor, as opposed to them just going back to the ER? And you mentioned those because the reason I bring up this example is it may not be applicable to you, but as you're talking about some of these hospital contracts, is a hospital, just like we have the hospitals paying us, is that, hey, if you're going to call and check in these patients, they're going to say, hey, here's the information I want you to gather. And what we can do is we can add that to the agenda so that maybe their COPD patients have these questions asked and are guided on these topics. But then also, if that hospital may say, hey, one of the things, too, we want you to really, really emphasize again and again is that if the patient's not feeling well, to call the hospital first before just coming to the ER. Because that might be an issue that we can mitigate over the phone, and as opposed to that patient just going into emergency room and costing us a huge expenditure for our Medicare spend. And so it is based on the best practices, but it can also be customized to a number of factors specific to the hospital you're working with, specific to the region or the area you're working with, and of course specific to the different conditions, so that each one of these is dynamically assembled based on the criteria that you specify.
Okay.
Let me ask you this. Do you have any existing relationships with hospitals that are utilizing this program where their case managers will put the initial data in, and then it's basically like if I was to partner with you in a hospital in this, could I give case managers or discharge planners access to a portal that when they have a patient that is discharging, they could funnel it in and then I get it and then we can take action, and manage that process? Or is it mostly done by, your partner, you and I, me going into the hospital, collecting the stuff and manually putting it in? So are hospital systems going directly into this, or is it people like us?
So yeah, I'll be very. So what we have now, one of our primary clients is a hospital in New York, and we go into their EMR, extract the data out, and populate the account. The social worker or head of social worker has access to log in anytime, pull reports if they want to, and see how each patient is doing. But then we also extract reports, and when we have our weekly and monthly meetings, we bring the reports to us that we have generated from our system to show them our outcomes. But that social worker, if she wants to, has her own access and a restricted access to see only their patients.
Okay, so this is a hospital where there's not a third party in this. This is the hospital and you and your company working directly to manage discharge planning, what's happening after the hospital.
Exactly.
There's not a third party. This is the hospital using your software.
Yeah, so Robert, to be even more clear, so we're in this example, we're providing both the service and the software. So in that example,
Right.
Now, other examples, a lot of times when we see the opportunity is that groups like yourself, like have a huge team that maybe looking to expand in other services,
Mm-hmm.
where you would be the service using this as a software platform. But we can't. So one of the things we have, and not to jump around too much, but we have an integration engine that can take a feed directly from an EMR, filter out the data, add only the patients that meet your criteria, and add them in. It's not a simple process, but it's one that we have the capability to do, so that it doesn't require data entry.
Let me ask you this.
This is Chad. So,
Go ahead.
go ahead, Rob.
Go ahead.
First, and then I'll ask.
Okay, so what has been your experience with working with I work very closely with a couple hospitals, right? And we've been talking about this very thing. With the way it works right now is they basically give us the referral. We do a lot of this through our own program. We call it DART, where we manage a lot of these things based on specific conditions. And so the question, the next level of this is going to where, there's actual some, they're not giving us access to, we're not communicating data, patient information back and forth. You know what I mean? We're basically getting a referral, then we're manually, collecting all the stuff and doing that stuff. Have you ran into resistance? Do you think hospitals would be willing to work with companies like us and your software as a third party to manage discharge planning to get this off their plate?
Oh, where you would be there, take place of their social work team?
Well, we would
planners?
not necessarily take place of that, but we would work with them, because what happens is, like you said, is when they leave the hospital, what happens after that, you know what I mean? And so,
I see.
there's a lot of hospitals I've talked to that literally are managing this with spreadsheets, and it's a laborious process. And so, where they may say, hey, we're going to go ahead and you're our discharge, you're out, our external partner once they leave the hospital, and you're going to do all these things and report that back to us, on a monthly basis, outcomes. But then again, there's the transferring, the HIPAA, and are they going to be more willing to kind of open that gate, do you think?
Sure. So let me first answer this. Say one of the things that we spend a lot of time in getting done is we're not an electronic medical record, but we did get certified by the ONC, which is the federal organization that certifies EMRs, for the security provisions of an EMR. And it was a very difficult process. We have the latest certified version, and we have the documentation to show you all the modules that we got approved for data encryption, data integrity. Everything we do, everything we touch is fully audited, and you have an audit access record to log in and see who looked at every patient record and what they touched when. So if you did have resistance from the hospital, I would show them, hey, our software is accredited by the same organization as your electronic medical record.
And that's the ONC you said?
Yes.
And what does ONC stand for?
Oh, it's the office. It's the I think it's Office of National Healthcare IT.
Yeah. I wasn't sure. I thought you said it, but I didn't catch it. So no worries.
Yeah. Yeah, and we actually just did a press release today on this. I can send you a copy for all the modules that we've been approved for. Okay. But it's the same group that certifies EMRs for meaningful use.
Okay.
So let me.
Yeah, and it's the Office of the National Coordinator for Health IT. Sorry, guys.
Hey guys, let me get the practical questions of utilization. So let's say that we as an organization, and then our franchise partners like Robert take this and they go and we use it and we go into the hospitals and we say, hospitals, we have this great software system. You give us clients and you tell us what their disease state is. We put their information in here and then it prompts us and we have all these follow-ups and we can we can prove that we can decrease readmissions based on all these prompts and these activities that we put into place. Is that kind of what you're proposing that we do? That we buy your software and then go to the hospitals and kind of sell that as a value added as part of our program, or what do you see as the end game?
It's a great question, and I don't want to speak for your business, but that's definitely one model we see. And another model is not just for the hospitals, but also for the skilled nursing facilities. So they're on the hook, now for quality measures for remission, and they don't have the time to do this, and are looking for a solution they can afford to go up to the most complex patients. Not every patient, but the most complex. And I think that those are two models that I see are being possible. It is also too, just as if you have one other alternative, and I'm just proposing ideas, is that obviously you have a visit program where you're visiting clients at home. If you are selling an add-on service where you're just calling to check in, but you want to be able to show the family members, hey, when we checked in, here's every question we asked, here's every answer we got, so that you can show, hey, here's all the things that we're covering with your loved ones. It may be an add-on service that we can possibly envision. Whether that's practical or not, I obviously don't know your business well enough.
Let me ask you this: are you mainly selling this to hospitals, or are you trying to go out to companies like ours and kind of get it to be the ground users? Because it seems like it's more naturally something you would sell to an ACO or an integrated system that maybe is in a bundle contract, or maybe as an ACO that they obviously are taking risks. Maybe they're Pioneer ACO, where they're having upside, downside risk. That would make sense, because then they would just have their own employees making calls without follow-ups and decreasing, or maybe even the Medicare Advantage plans, right? Where anyone who's fully risk for that patient, it would make perfect sense. And for us, I see the value. I mean, if we could use this and we could somehow have access to it, some of our more sophisticated franchise partners would probably want something like this to offer. I just don't know if they have the manpower. I mean, the big question is who's going to pay to do all the follow-up and to make sure that the telephonic disease management is happening on a regular basis and documenting all of that. We could do it, but that's it. I mean, I love the concept of it, and I would love to explore with you guys further how we could implement it in a cost-effective way that we can both win from it.
Yeah. So, Chad, I think that a couple of things there. We're seeing it more and more. The cost to add a hospital employee can be $70 to $80,000, right? Just for the most basic one. So, if you had a solution that could be done with someone that is and price it so that it's underneath that threshold, they're going to look at paying for that as opposed to trying to hire someone else and all the red tape with unions and things like that they have to consider. With the couple factors that are driving this more is the readmission penalties are getting higher and higher, and also groups are getting hit more, or hospitals getting more Medicare spent for beneficiary penalties as well.
Right.
That they're considering investing in a solution. I mean, those are readmission penalties are running from $1 to $3 million typically. Like this service, typically doesn't. You can find a way to focus on a certain segment of a population, in a way that they're going to see an ROI worth exploring.
Yeah.
But
so let me ask you. Let's say we get deep and we start talking about doing this. Do you foresee this being rolled out through home care companies like us more, or more through ACOs, Medicare Advantage, and hospitals? Who's your main strategy? Because what I'd hate to do is implement a lot of time, effort into maybe putting together a partnership with you guys, and like the hospitals, Medicare Advantage, and then all other home care companies have something similar, and it's not as much of a competitive advantage as you thought.
That's a fair question. So, we saw our market primarily as hospitals and skilled nursing. But let me explain to you, we're very new. So as a service, we've been out about 3 years. As a software, we're about 6 months old. we don't know where the market's going to be. The problem, the most expensive component of this is not the software, as you know, it's the labor. And so
Right.
if in a lot of ways, it's going to be who can assemble the team to do this in the most affordable way possible is going to be the winners. And with it, and we designed the software specifically so that non-licensed people can be effective at doing this role, because the critical thinking of what to ask has been done for them. How to ask it has been done for them. And then
I
all the
love the
documentation.
concept. It actually it fits us perfectly because we already have staff that could probably already be making calls, and we already have schedulers who are checking in on our clients, caregivers. It would be a matter of really training the caregivers and the family on those disease management interventions that you're talking about. And it wouldn't be too much of a stretch. It would be an additional cost and maybe some additional burden for our office staff. But if we can ensure that we were getting
life replacements recommended, there's been a lot of issues with this thing. I built a house, so I put this in there.
Is that Robert? I can't hear him very well. I'm sorry. Are you guys still there? Tim, are you still there?
Yeah, I'm here.
Did we lose audio for Chad and Robert?
Yeah, it looks like we did. Are you still there? I just lost audio on you.
No, I'm here.
Okay.
Let me just.
Do we have Robert or Chad?
Correct.
Robert looks like he's still on. Let me just text him, or let me just
It sounds.
You might email him.
Yeah, I think we lost Chad. It sounds like Robert might be talking in the background.
Yeah. You know what?
Let me send him a quick email to you.
Okay.
Right, so I am the original owner of the house. I built the house. You guys have insured it 100% of the time. From the time it was brand new. So from the moment it was brand new, you guys have insured this thing. So there's nothing pre-existing about it. From the time you guys started insuring it, it was brand new. And the issues that came up, I chose not to file a claim.
Is that Robert back?
I think he's online. I don't think he's on the phone.
Okay. Yeah. That shows phone connected, but
I think he may have stepped away.
okay. Is that background noise from his phone, or is that from your office?
I thought that was your phone. I hear it. It looks like you're the one saying that clicking noise.
Sounds good. Let's go ahead and, who do I call and send that person out?
Yeah, and I just muted myself.
Yeah. That's right. Well, it's workable.
Sounds like maybe you had to take a call or something, but I don't know why we lost Chad, unless his battery died or something.
No, it was weird. I think it almost, you know what happened was I think Chad's audio just cut off, and then I just heard Robert in the background. I thought it was Chad. And so at first I thought Chad's audio just got muted down, which is really weird. But now I think he just got cut off, so. All right, let me see if, it's unfortunate. I hope he didn't go too long without realizing that. You emailed him?
Yeah, I did. Yep. I think that bang was if you heard like a couple minutes ago, that with that email going in, it's like right after.
That's what I'm saying. If this, like, $540, and I have a number of that, if this was not a storm of lightning. But I don't know how you, electric meltdown, because of wiring problems, if that happened, yeah, that is not, related with it. We didn't have really a fix of the problem altogether. We don't fix it, and then that's down again in 6 months. So, this is a different issue all the time. The fix was not a complete fix, because the system shouldn't melt down.
I can jump off for a second and try to call Chad back. I have his number because he called me.
Why don't you do that? And then I'll hang on, and then you can just, if you just keep the participant window open, you can tell if he comes back on.
Yeah. Okay.
Okay,
I'll be right back.
on this one. Okay.
No, I agree with you. No, I agree with you, but I'm just saying, for example, listen, I built home, I'm very good with construction, with electrical issues happening in homes, and what normal wear and tear is, and I also know that there are some contractors out there that will come in and underbid everybody, and give the absolute lowest possible bid for the lowest possible work, done, and it is a temporary band-aid, and they did not address the entire thing. That's my concern, is that we have, on behalf of the insurance company, their representative that is being approved, the absolute lowest, cheapest thing, and that's why we're approving, that we're not actually fixing the whole thing. So I'll fix this thing, but in a couple of months, if I have a meltdown again, this is 500, whatever it is, it's going to go towards the stuff. So. Okay.
Okay. That's what's going on. So that was, there was a Bible. Okay, so
Okay, I've got tenants.
Donna Lennox is another one. It's not here. Yeah, Donna Lennox is ours. She's an Edgewood. So, yeah, so you're fine. I'm waiting. She has a caregiver that's supposed to be coming with her too. So. Nice having things that she needs to say. And I'm gonna send out an email to give the process, because what I'm gonna do, well, Prentice, I will tell you guys, I hate emailing, I'd rather tell.
Prentice. Prentice. Prentice.
So, just so you guys know how the process works, and how I'm going to be doing this as we move forward. So.
Amada senior.
Yes. Just hurry up. Just listen. Okay, well, so no. Tell her I'm making. Yes, she did.
So I'm just gonna basically pay them directly, correct? And that's good.
Hey, can I grab you and Maria for about 3 minutes?
Okay, all right, thank you. Hello, guys. Are you guys still on?
Hey, Robert.
Hey, sorry about
we
that.
Are. Chad got cut.
Yeah, I had to. I have a.
Chad got cut off.
It's like 5 degrees out, and I have a rental property that I had a furnace explode, and I have an insurance company doing what insurance companies do, and that's basically trying to find a way not to pay the bill. So I had to step out and give them a piece of my mind.
No. Insurance companies and home warranty places are the worst to deal with.
Oh,
they'll fight tooth and nail.
Yeah, she tried to tell me that the HVAC might have had a pre-existing condition.
Sure.
I said,
You know,
I'm like,
do that, and, yeah.
I was dumbfounded. They go, is this a medical condition, a clause that's in this, insurance policy here? I mean, I built the house. I bought it when it was new. You were insuring this thing when it was new. Anyway, I was just, my blood boiled. Hey, so sorry about stepping away. Very impressed with the program. Tell me a little bit about the type of reports back that you can analyze and provide to our partners, the hospitals, the rehab facilities, on outcome stuff that we're doing for them.
Yeah, a lot of different options here. So here's a basic report, right? So we have this is you can this is just on activities. So reports all kind of function the same way. There's a lot of filters you can choose from. And so you can choose, only show me certain locations, only show me, certain conditions, certain ACOs, certain groups, and then, certain payers. And then, I got to move this thing out of the way I got the bar here for the zoom away. So I click generate report. And this will just give you some, so let's say one of your customers just wants to know, okay, show me all the activities that you did for my group. And each of our reports has a cover page because, PHI for health information. And you can see here, this can be exported to Excel, patient name, what the unit was, location. In this case, it would probably be one of your franchise locations. Who did the activity, what was the name of the activity, and then how long the activity took to complete, and the data was, go scroll here, you see the data was assigned, and the data was completed. So a very just a detailed report of just show me what have you done for me,
right.
From a, just a kind of a sum level. Other reports we do is, okay, well, I want you to, you can get that also then from a specific patient if you want to. So let's say, hey, this patient readmitted. What'd you guys do to help them? You can report patient history detail, and what this does is this shows you. I'm gonna put in a specific patient name, just patient specific. What everything you did, for that patient, every question you answered, every response they gave. And so again, the cover is going to have,
sure.
It's going to have the name of every question, the activity name, the actual question you answered, and what the response was. And that gets to show them everything you asked. The other reports we have show, okay, well, we wanted you to gather specific information for us. Show me what results you had for these specific questions. So we have a question response report that again can be filtered down into certain categories, and then pulled out to show only certain. This is every question we have. You can have it include only specific questions or specific activities that were asked, and to show, hey, we wanted you to gather this information to find out these data elements. Show me what your team collected, and this will give you a report. You can then export to Excel. This is every question that is that type of question, that specific question, and export it out to Excel. They can see the data. one of the more advanced features we haven't even touched on is that if you're able to get your team to track what other services they're using, and if that patient goes back to the hospital, we have some really interesting financial reports that show if that patient, where that patient went to and if they went out of network. So the spend detail report, because if you're asking questions, this is 4 or 2 more questions to ask. Hey, did you go back to the ER this week? Are you still using that home health? Which home health are you using? And can track if it's out of network for the hospital. And so this one report shows if you're asking the condition, and it takes a while to explain this report because a couple things have to go into it for it to be asked for it to work.
Sure.
But you can have reports that show every care setting they were at.
And obviously
end date was.
we're collecting that in our calls, right? We're saying, did you go to the emergency
Right.
room? Okay, you did. What emergency room? Did you go to urgent care? What urgent care? So this is data you're collecting. Now you're not collecting spend data, right? Because you wouldn't. You're just go ahead.
Yeah. No. So the spend data. So the way we have it now, and the way we're changing it, is that we have an open field to know what that spend data is.
Okay.
But what we're putting in is we're pulling in claims data to auto-populate based on what's known about that patient, a estimated sum per day for a sniff, per visit for every kind of service, so they can have some idea based on the days of stay and also the number of services delivered, what a range of what that spend was. And we can even measure it against a benchmark for the hospital.
Okay.
Hey, Ryan and Robert. I talked to Chad. His app stopped working. He couldn't get back in. So, but what he asked is that we, Ron, potentially get together on the 7th before March 7th and do a little bit deeper dive. If not, we can look at another time. But we need to look at our travel and see if we can make that work, which I think we probably can. But so I just wanted to let you know it's back in, and we have about 5 minutes left until the top of the hour. So,
right. Robert, other reports are just for your franchise owners to see how productive is my team at getting done with these activities, so I can make sure they're doing the work accordingly.
Right. Well, one of the things that I'm talking with a couple of these hospitals up here in Seattle area is looking at the hospital readmission reduction program, those 7 high risk readmitters, is managing those people when they're discharged, whether we take them into care or we place them, really tracking outcomes on at the end of 30 days for those specific disease states. So at the end of the month, you discharged 100 people into our care. 30% had CHF, 30% were COPD, and this was your readmission rates for the month. And these were the facilities that were that had the readmissions, and which ones didn't. And then basically, of course, that data grows and grows and grows, where we could really help identify who the offenders are in the community causing readmissions, for certain disease states, and which ones aren't causing the problems. So, I imagine that the program here probably has some type of bigger data features similar to that, correct?
Absolutely, and we do that now. And I want to be careful at time, but also, we don't have to necessarily wait till the 7th. Robert, if you want to, I can take that question and kind of walk you through a case example before then of exactly how we do it now with one of our local hospitals.
Okay.
If you want to, and so I can reach out to you and Tim and I to before the 7th, just to kind of answer that question, but it does take a few minutes.
Sure.
It won't take a full hour, but just about 15, 20 minutes to walk you through a case example to show you exactly how that can be done.
Perfect. I'd love to do that.
Then we'll Do you want to do that? Do you want to schedule that while we have you on the call?
Yeah, that'd be fine.
Okay. Let's. When I'm actually better this Friday. If you have time on Friday.
I am going to be out of town. I'll be back in town on Monday. I leave tomorrow morning, and I'm not back until Saturday night. So if we could do it first part of next week would be a better time for me.
How about Tuesday? What's your Tuesday look like?
Tuesday the 24th. That will work.
Okay. Is there a time that works best for you?
Probably first thing in. Let's see here. I know I'm doing a conference call with the rest of the team on that day. Let's see here, the 24th. Let me look at my calendar. Just got 11 o'clock. Either 8 a.m. First thing in the morning, my time.
Okay.
Or
That works.
yeah, let's do 8 o'clock in the morning.
Okay, that's you're Pacific, right? You're
Yes.
California also, right?
Yeah. I'm in Seattle. Yeah, I'm in Seattle area. So
Okay.
We'll be prepared. Okay. All right. Well, Robert, I apologize. We have to get on another call, but we'll send out the invite shortly, and then we'll pick up that answer from there.
all right. Hey, thank you for your time. This is pretty impressive stuff. Definitely something that I know I'm interested in looking more into with you.
Thanks. No, we're looking forward to it as well.
Thank you so much.
Hey, safe travels this weekend, and we'll talk next week.
All right. We'll see you. Thanks. Bye bye.
Okay. Bye bye.